the commissioners and other non-voting members and others that are on this call. And welcome to the Patient Protection Commission's public meeting. I am Dr. Ikram Khan, the chair of the Patient Protection Commission with the Department of Nevada Health and Human Services. I'd like to call this meeting to order. Mr. Felipe, please conduct our roll call.
Sure. Thank you, Dr. Khan. Joseph Felipe for the record. Commissioners, please identify yourself when I call your name so we can ensure that you are present. I'm going to start with the voting members today. So starting with Commissioner Jalen Behunin. Jalen?
Yeah, present.
Okay, present. Thanks.
Thank you.
And then Commissioner Dr. Bio-Curry Wenchel, are you here?
Present.
All right, thank you. And then Commissioner Walter Davis.
Present.
Commissioner Flo Khan is going to be absent excused today. And then Commissioner Marilyn Kirkpatrick.
I'm here.
Thank you. Commissioner Andrea Peterson.
Here.
Commissioner Bethany Sexton.
Present.
Thank you. I didn't skip over you this time. Commissioner Wendy Simmons.
Present.
Thank you. And Chairman Dr. Khan.
Present.
Perfect. Dr. Khan, we do have a quorum. We are going to just really quick see who's here as far as our ex officio non-voting members. So starting with Director Richard Whitley from Health and Human Services.
Here.
Thank you. And Insurance Commissioner Scott Kipper.
Here.
Thank you. Executive Officer Celestina Glover.
Here.
And Executive Director Russell Cook from the Silver State Health Insurance Exchange.
Here.
Great. All right. Chair, that concludes roll call and we can move forward.
Thank you, Mr. Felipe. Before we go to our next item, I would like to thank Commissioner Kirkpatrick for officiating in my absence the last meeting. And also for the record, I had requested her if she would be willing to serve as vice chair of this commission, and she had very graciously accepted it, for which I'm very grateful, Commissioner Kirkpatrick. And so moving on to the next item, public comment. Mr. Felipe, what do we have today besides the written ones?
So going to offer anyone joining by the computer or phone an opportunity for public comment now. So no action may be taken upon a matter raised under public comment unless the matter itself has been specifically included on an agenda as an action item. If you'd like to provide public comment today through the telephone, you may join the meeting by dialing 775-321-6111. And when prompted to provide the meeting ID, enter 902-117-927#. And then if you are joining by phone today, you can press *5 to raise your virtual hand. And then also if you're joining by the computer, you can use the raised hand function through the Teams platform. So anyone wishing to provide public comment today, please raise your hand. I'm showing, and just so we know, sorry, I forgot to mention, comments will be limited to 3 minutes per person. Please state and spell your name for the record as well. Starting with Shauna. Go ahead and unmute.
Good morning. Can you hear me okay?
Yes, we can. Thank you.
Okay, thank you. My name is Shauna Ross, and that's SHAWNAROSS. And thank you for the opportunity this morning to make a public comment. I'm a speech language pathologist and pediatric private practice owner of 18 years. My office is in Northern Nevada. I also serve as the state advocate on reimbursement for Medicaid and private insurance for the Nevada Speech Language Hearing Association. As a quick mention, NSHA is actively working with legislators on a bill so that Nevada can join the Interstate Compact for licensure for speech language pathologists and audiologists. And I included a link to that, the website that shows the other states that are part of that compact. I believe there's 30+ states that have now put legislation through to be part of the compact. So we're excited about that potential. But more directly, I'm here to make a comment regarding the speech swallowing codes that are not being reimbursed through Nevada Medicaid. The CPT codes are currently reimbursed at $0. They are 92612, flexible fiber optic endoscopic evaluation of swallowing, which is fees, 92511, nasopharyngoscopy with endoscope, and 31579, diagnostic laryngoscopy with stroboscopy. It's our understanding that these codes are included in the Medicaid fee schedule, but are reimbursed at $0 for speech pathologists. Physicians can be reimbursed for these codes. However, it is reported in Southern and Northern Nevada that physicians are not completing these procedures, and it's presenting a barrier to care. And it is also difficult to recruit and employ a robust workforce when receiving payments of $0 for this highly skilled work. These codes are within the scope of practice for speech language pathologists and are reimbursed under other insurance plans. With the written comment that I submitted, I also included a joint letter that was submitted to Medicaid on November 8th by the American Speech Language Hearing Association and NISHA. So we ask that legislators support these requests in the budget and with any policy changes needed in the 2025 session. And we're happy to provide any additional information and look forward to hearing how we can continue to advocate. So thank you.
Thank you, Shauna. Appreciate your comments this morning. Carissa Pierce, you have your hand raised. You can go ahead and unmute. You have 3 minutes.
Thank you. Good morning. Thank you for the opportunity to provide public comment today. My name is Carissa Pierce, Carissa Pearce, and I am the Health Policy Manager with the Children's Advocacy Alliance, CAA. CAA is a nonprofit, independent, nonpartisan organization. We aim to cultivate public policy that allows for every child to thrive in Nevada. And as such, we are strongly supporting actions that increase the delivery and access to health resources while also maintaining medical integrity of patients. We have a really big health provider shortage right now in Nevada, and it's imperative that we address these issues as they're increasing health disparities among children and families. The first piece of our public comment today is related to agenda item 4. CAA has been brainstorming and collaborating with community organizations to also try to think of creative ways to recruit and retain providers in the state. And right now there are very few postdoctoral fellowships in Nevada unless a resident wants to study emergency medicine. So this means that residents who are training in Nevada are then leaving our state to go find a fellowship somewhere else. So expanding our accreditation program to allow for more graduate medical education opportunities would mean that more residents are able to stay in Nevada for postdoctoral fellowships, and then they will likely stay in Nevada to practice as well. CAA is also in our research phase of better understanding how Nevada may be able to expand scope of practice for advanced practicing clinicians to reduce the provider shortage. We're exploring, exploring solutions that protect patients and ensure providers are able to deliver high quality and competent care. I would also like to give our support to agenda item 5. We believe creating an interstate compact for healthcare providers will allow for more training opportunities and attract licensed providers. And it would also make it a lot easier for patients to receive care in Nevada instead of leaving our state for care. Right now, many families with medically involved children are already leaving the state due to a lack of pediatric specialists. And in many cases, these treatments are necessary for their children to live. So it's an incredible burden on the medically fragile children and their families. And it's important to note that these children are leaving the state because we don't have resources in Nevada for them. So many of the families cannot find the treatment they need, and so they're having to travel out of state and are suffering from worse illness or in some cases losing their lives. So we have an opportunity right now to help these families by allowing for flexibility and coordination between states. Thank you so much for the opportunity to provide public comment today. We very much appreciate your consideration and your efforts in this work.
Thank you, Ms. Pierce. Appreciate your comments. Anyone else wishing to provide public comment today? If you're joining by phone, please press *5 or raise your hand through the Teams application. Chair Khan, I'm not seeing any further public comment requests. You're muted, Dr. Khan.
Sorry about that. You go to the next agenda item, number 3, possible action, which is review and approve minutes. I'm presuming that all the commissioners received the minutes of the previous meeting. So if all of you have any questions, changes, modifications to be made, please let us know right now. Otherwise, we'll have the motion to approve the minutes as presented.
This is Walter Davis. I motion to approve the minutes as presented on May 15th.
Great. Do we have?
And this is Wendy Simmons. I second.
Thank you. Any opposed? None. So the motion carries. Minutes stand approved. Thank you very much. So the next item on the agenda is presentation on opportunities identified to address healthcare workforce shortages from other states. So we have allocated about 15 minutes, which is 10 minutes of presentation plus 5 minutes of Q&A. I understand the desire of the commissioner, obviously, and myself to get more information. In the interest of time, we have allocated some time frame. Hopefully, we can maintain that, but I would certainly understand if the commissioners have additional questions. So can we go ahead with the next presentation from the people presenting?
Yes, we have Kelsey George. She is here from the National Council on State Legislators. Kelsey, we'll go ahead and hand it over to you.
Yes, can you see my screen and hear me just fine?
Yes, we can.
Fabulous. Well, thank you, Chair Khan, and thank you for inviting me to speak today, Joseph. My name is Kelsey George, and I'm a Senior Policy Specialist with the National Conference of State Legislatures. And my portfolio includes all things relating to health workforce, as well as some access to care topics like emergency medical services, but I'll be focusing on health workforce for this presentation today. Now, if you listen to the Nevada Interim Committee on Health and Human Services meetings on March 11th or May 13th, much of the information that I present today will sound familiar to you. Before I jump into state legislative trends and examples, I want to take a moment to introduce the National Conference of State Legislatures, or NCSL. NCSL is the bipartisan organization serving state legislatures. We provide a variety of services to our members, including state legislators and legislative staff. Some of these include legislative tracking, policy publications, individualized research on policy topics, presentations, much like the one I'm providing today, and meetings that bring policymakers together. Now, the main takeaway for you all is that NCSL is a bipartisan organization, and NCSL staff, like myself, are nonpartisan. We do not advocate for or against any state policies, and all of the information I provide today is purely for informational purposes. Now, for the sake of time, you'll notice I'm skipping a few slides throughout, but I wanted to make sure that you all still had the information for reference. So with that, as part of our work as NCSL staff serving state legislatures, we field questions from legislators and legislative staff regularly. And as you can see from the word cloud on this slide, it represents some of the most common requests that NCSL staff answered on health topics in 2023. Now, you'll see several topics that cross into health workforce, including Medicaid, long-term care, nursing, training requirements, telehealth, and licensure. I think it comes to no surprise to all of you that health workforce is one of our hottest topics in 2023, and we continue to see this trend going into 2024 legislative sessions. Now, we are also in the midst of developing a health workforce database that will track enacted legislation across the 50 states, DC, and the US territories. Now, I want to note that the numbers on this slide are preliminary from our initial searches, but some trends that we've identified so far are captured here. Now, you can see that we've tracked enacted legislation in behavioral health, primary care, and many other occupations, including occupational and physical therapy and pharmacy professions. We also continue to see states pursuing a variety of workforce strategies, as you can see on the right side of this slide. These include things like licensure and certification, including interstate compacts and professionalizing emerging occupations, as well as scope of practice, recruitment and retention, and education and training as well. Now, I'm going to focus on just a few state strategies with the rest of my time today, and those include data collection and analysis, recruitment and retention, licensure portability, and telehealth flexibilities. Now, as I mentioned, I'll breeze through a lot of information and a lot of state examples during my presentation, but I'm always happy to circle back during Q&A or to follow up after today's meeting if there's any pieces that you would like to dive deeper into. Now, the first step when we think about health workforce and state interventions is to understand what interventions may be necessary and for what professions. And the first part of that is data collection and analysis. Many states are going beyond counting heads via licensure processes to understanding who is providing what services, to whom, and where. Now, there are several examples highlighted on this slide across long-term care, like Colorado and Florida, behavioral health, like Georgia and Illinois, and across the entire workforce, like Indiana and Utah. Now, I want to note here that data collection and analysis are critical to the policymaking process, and they may provide a baseline to compare policy interventions against in the future. So next, I want to turn to recruitment and retention strategies that we're seeing across states. When it comes to recruiting new professionals into the workforce, many states are looking towards career pathways or career pipeline initiatives. And you'll see 3 examples on this slide. So Colorado established new pathways that focused on behavioral health in 2019. And Indiana's largest community college, Ivy Tech, established a certified nursing assistant bridge program for direct care workers. And this came after a 2018 legislative bill that I highlighted in the last section that updated the information collection process during licensure renewal processes and showed that this was a gap in their educational pipeline. And Nebraska established a program to incentivize local high school graduates to pursue healthcare careers in rural areas. And you can read more about the pathways at the K-12, community college, and post-secondary level at the report linked on this slide. And I'll include several resources throughout my presentation today and at the end. So graduate medical education often serves as a critical pipeline for physicians. This sort of falls in between the education and training and recruitment and retention areas that I mentioned earlier. And we know that graduates are more likely to practice in the area where they complete their residency. And rural programs or rural rotations as part of their clinical rotations tend to retain medical graduates in rural communities. Now, historically, GME has been funded through Medicare, but states have significant leverage through Medicaid and state appropriations. Now, there are some unique examples on the slide here, including Florida and New Mexico, which have leveraged GME funding to expand residencies for specialties and for non-traditional residency sites, including federally qualified health centers. You can also see Iowa and Nevada have appropriated state funding to start new programs, which is a cost that's traditionally not covered under Medicare GME payments. Now, for more information, you can visit our brief on GME state funding linked on this slide. Moving from recruitment to retention, to retain existing professionals in the healthcare workforce and reduce high turnover rates in certain professions, many states are turning to financial incentives. These may include loan forgiveness and repayment programs or tax credits or deductions. Now, many of these programs were originally established to address physician shortages in primary care, but today we're seeing many states expand these to address other healthcare workers, like behavioral health professionals or direct care workers. Now, as you can see from the examples on these slides, most programs have a practice requirement. So professionals must commit to practice within the state for a certain number of years. And the dollar amounts and requirements for each incentive program vary greatly. Now I'm going to touch on licensure portability briefly, and since there's another presentation directly following mine on interstate compacts from Daniel Logston at the Council for State Governments, I'm going to breeze through this section a little bit. One quick note that I'd like to make on interstate compacts, however, is that not all compacts are created equal, and Daniel will dive into this a little bit more. They each operate slightly differently, and based on the model legislation that states must enact to participate, they have different requirements. I also want to note that research on the outcomes of interstate licensure compacts is generally mixed. It's difficult often to separate this particular policy strategy from the many others that states pursue simultaneously, especially amid the COVID-19 pandemic. Now, many studies have found that compacts have facilitated greater use of telemedicine, but it's important to note that the evidence was often limited or not statistically significant, and I'm happy to follow up with links to several studies after today's meeting. Now, I believe Daniel will also provide information on universal licensure, so I will not dive into that today. But beyond those measures, states may also develop reciprocity agreements with specific states or set standards for licensure by endorsement for health professionals that meet certain requirements. And you'll see several examples here. So Maryland, Virginia, and DC have entered reciprocity agreements with each other for physicians to practice across those state lines. Hawaii has streamlined their endorsement processes. And South Dakota has created a temporary license, certification, and registration for certain health professionals. In addition to reciprocity and endorsement, states may also waive certain requirements for licensure. And you'll see on the map here that several states allow exceptions for licensure requirements for episodic care, consultations, or other specific circumstances. Now, two examples on this slide, Idaho and Oregon, are specific exemptions for services that are delivered via telehealth. And lastly, we know that many of these portability strategies may shift providers from state to state, but they generally do not increase the total number of professionals available. So some states are altering the licensure and training requirements for international medical graduates, as shown on this slide. As you can see, Colorado and Minnesota have established support programs that help international medical graduates navigate the licensure and training processes. And Idaho and Tennessee created temporary licensure for international medical graduates as they complete the requirements for full licensure. Now, lastly, I'm going to cover some interventions we're seeing related to telehealth, as I know this is an area of interest for you all. So states have many policy levers relating to telehealth, and I want to note that while Nevada and many other states require full licensure within the state to provide services via telehealth, some states have created limited licenses or other exceptions to create an expedited process and increase access to care provided virtually. Now, several states have also established study or oversight committees, as you can see on the left of this slide. And you can find more information on these state examples and other occupational licensing trends on the article that's linked here as well. Now, I've covered many of the strategies in this graphic already, so I'll focus specifically on special registration and licensure for providing services via telehealth. Under telehealth registries or special licenses, providers typically must have a valid, current, and unrestricted license in another state. They must not be subject to any past disciplinary proceedings. They must maintain and provide evidence of professional liability insurance. They must not open an office or offer in-person treatment in that state. And they must register annually and pay a fee with the appropriate state licensing board. Now, the map on this slide shows in green the states that have active telehealth registries or offer a special license for providing in-state telehealth services as of September 2023. As you can see, this includes 12 states and the Virgin Islands. And there are a few examples on this slide and on the next slide that demonstrate how these registries differ across the professions that they cover and the requirements that they set. So as I wrap up my presentation today, I also want to share a few other trends we're seeing relating to telehealth. In particular, the ability to obtain reimbursement for services, prescribe medications as necessary, ensure patient access to broadband. All of these may have an impact on the ability for out-of-state providers to provide effective telehealth services to residents. So with that, I know I covered a lot of information today, including trends, legislative examples, and resources. This slide includes a few more resources from NCSL on health workforce, and you can find additional state legislative examples for reference throughout. And in closing, here's my contact information in case I can be of any assistance or field any questions after today's meeting. But with that, I'm happy to take any questions.
Thank you very much. I really appreciate the presentation. Very useful, helpful. I would request our Executive Director, Mr. Filippi, to follow up with the questions. I'd request the commissioners to kindly raise your hand so that he can recognize you, and then we can go for the question hour sessions. Mr. Filippi, you want to see whose hands are raised?
Sure. Sure. If any commissioners have any questions for Ms. George regarding her presentation, or want to request any follow-up information, Mr. Davis, go ahead.
Yes, thank you for the presentation this morning. One question I just have is any thoughts on the credentialing component with, getting the licensures, kind of expedited, but, how are the payers? Is there a relationship correlation with the payers getting the providers on plans a lot faster with this process?
That is a great question. To my knowledge, most of the changes that I covered from the legislative angle specifically address the licensure requirements and not on the payer side. So it's going to expedite several of these initiatives, tend to expedite licensure in that initial phase, and then the credentialing follows that. I believe there are other specific requirements and processes for individual payers, for whether that's Medicaid or private payers, for that credentialing process. But I'm happy to also look into that and follow up with you.
Thank you.
Thank you. Anybody, the commissioner has a question?
Bethany, you have your hand raised. Go ahead.
Thanks so much, Kelsey, for the information. Is there any additional insights that you can give us? I think you mentioned that states that have these sorts of compacts or reciprocation often don't necessarily find that there's a net add to overall providers. So can you talk a little bit more about that?
Yeah, so interstate compacts and reciprocity and endorsement licensure.
Just a second, if I may. We just want to make sure there's no duplication in the next presentation and what we are talking about in the interest of time. So go ahead.
Yes, I will keep it very brief. Just to note that interstate licensure compacts, reciprocity, and endorsement, all of those allow providers to shift from state to state and practice across state lines, but you're still operating with the same baseline number of providers across all of the United States. So when we look at several states and those surrounding Nevada, for example, that are also experiencing shortages, there's still a finite number of providers that we're pulling from in that particular initiative.
Thank you. Any other commissioners you identify?
Not seeing any additional hands raised. Any other questions from any commissioners this morning? No? Okay. Ms. George, thank you so much for your time this morning, and we'll be sure to follow up with any questions that we might have.
Thank you very much. Appreciate it. So moving along to item number 5, which is presentation on national trends in occupational licensing policy. Same here. 15 minutes and 10 minutes plus 5 minutes of question and answer session.
Thank you. And we have Daniel Logston from the National Center for Interstate Compacts within the Council of State Governments. He's going to provide us with a presentation regarding national trends in occupational licensing policy. Daniel, whenever you're ready, please go ahead.
All right. Let me see if I can. Let's hope everyone sees one slide.
Yes, we can
Okay,
see it.
great.
We can hear you.
All right, thanks. Thanks, Chair Khan and Joseph, for inviting us today. My name's Dan Logston. I'm the director of the National Center for Interstate Compacts here at the Council of State Governments. Just briefly, I got a somewhat easier than Kelsey. I don't have to cover a lot of subject matter, but I will skip over some of these slides in the interest of time. CSG is a membership organization for states. Every state's a member. We provide technical assistance to states on a wide range of issues, including interstate compacts. We serve all 3 branches of government, and we were founded in 1933 at the University of Chicago. We founded the National Center for Interstate Compacts in 2004. So we've been around about 20 years. We provide technical assistance to the states about interstate compacts, working through interstate compacts. We develop interstate compacts and evaluate them. So an interstate compact, every state's a member of about 24 interstate compacts. These are just states coming together cooperatively to address problems that are either bilateral, regional, or national. The good thing about them, they protect state sovereignty. They allow the states to deal with issues instead of having a federal mandate. There are plenty of issues where, it would make sense to have an act of Congress or the federal government provide a solution. But a number of issues over the years, the states have wanted to deal with directly. Something like, driver's license. Your driver's license is issued because of interstate compact, not an overarching federal law. So again, these allow states to come together with one voice and speak to issues, either again, bilaterally, regional, or national. There's over 250 interstate compacts in existence. Some of those are border compacts. They deal with things from like, occupational licensure, obviously, but, low-level nuclear waste transportation. In Nevada, you've got the Lake Tahoe compact between California and Nevada. So for these licensure compacts, we've really seen an explosion of interest over the years from states. We're currently a part of a cooperative agreement with the Department of Defense to create up to 10 compacts that we're working on that cooperative agreement in next year. We've developed not 7 compacts under that. We're working on one for athletic trainers, respiratory therapists, and then we've got one more spot to fill. Since 2016, 51 states have adopted these. 42 states have adopted at least 3. 356 separate pieces of licensure compact legislation have been enacted, and then 16 professions, and we got 2 in development, and we have 1 more spot. Only about 6 of these are actually operating. We'll have 5 come online next year. And then subsequently, when the states meet their threshold to stand up these compacts, you'll see even more come up. So right now there's medicine, nursing, PT, the EMS compact, and the psychology compact, which Nevada is a member of, are the only ones currently operating. But again, we've got more coming online next year. This this is in your packet, but you've got 3 compacts with at least 42 states. Counseling has really exploded. Social work will get over 20 states this year as states look for solutions around behavioral health and mental health. But nurse licensure compact, medical compact, and the psychology compact all have 42 states. And there's a heat map, again, that's in your packet. I like to have this slide available just so, these aren't written in a back room with certain organizations or certain states. It's a long process. We're a transparent process. One of the things that we spend at least 2 to 3 months on is stakeholder review. Once an interstate compact gets to the legislature for action, these are contracts between or among the states. They can't be changed substantively. So we have to vet them and ensure that, we've addressed all the issues. Stakeholder review, stakeholder feedback is crucial to that component of it, because, legislators expect that, again, mostly because they can't change them once they get in front of them. So benefits for practitioners, increased mobility. Obviously, it leverages telepractice, which Kelsey kind of touched on, and then supports relocating military members and their families. That's why DOD believes in these so much. Every state does things for military spouses and licensed professions. There's even an overarching federal law now, although it exempts compact professions. But what a compact provides a military spouse in the licensed profession is regulatory certainty, because it's the same every time they have a change of station. And then for the licensing boards, the biggest benefit for licensing boards, it enhances their ability to protect the public in an environment where you've got interstate practice. That's the access to the compact commission shared data system. And it increases the ability to bring in high quality practitioners. They agree on a uniform set of license. You can't create a licensure compact for a profession if the licensure requirements aren't within a range for many states. If there's wild variations on requirements or there's wild variations in scope, those professions aren't good candidates for compacts. You really don't see that in the health and allied health professions. And again, states like them because they protect their sovereignty. They can strengthen the labor markets. We'll believe that'll bear out over time as more of these become operational. And there was a lot of interest from the federal government in the last decade. I think starting in 2014, certainly with the North Carolina dental decision. We actually worked with NCSL and NGA on a couple of Department of Labor grants around state licensure and how to help states streamline state licensure and be more innovative to that. There was a lot of talk about federal licensing. And again, we think a compact's the best way to push back against this. All right, and so some additional considerations. So again, if you've got wild variations in scope or you've got wild variations among the states as far as licensure requirements, those professions aren't good candidates for a compact. All compacts thrive on uniformity. The lack of uniformity makes them unworkable in many ways. And then the size of the profession. What we found is a profession needs at least 30 to 50,000. Most of the profession we've worked with have over 100,000 members in the profession. But if the profession isn't at least 30,000 or more, if it's not licensed in more than 30 to 35 states, again, these aren't good professions for compacts. We don't just sign any profession up that wants a compact. We vet them thoroughly and bring in the states to do that as well. So there's three, I think Kelsey touched on this as well. Here are the types of interstate compacts that we currently have. So you've got mutual recognition. That's either through a multi-state license, like the nursing compact, for instance, or mutual recognition, a privilege to practice model. Telepsychology and temporary in-state practice. That is for psychology only. It is purely telepsychology, or excuse me, telehealth compact. It's got a 30-day emergency provision to practice in the states if there's some sort of issue with the client. But again, it is purely for telepractice. And then expedited licensure is only the nursing compact. And so I want to also talk about universal license recognition. You're seeing a number of states go this way. What we don't have in here also, Florida's had this for a while. Arizona just added it in recent legislative sessions, is a telehealth registry. So we were expecting more states to add those this year. We're currently in the process of updating all of our ULR resources, but we're not aware of any states that did the telehealth registry again this year. We expect those to become more common. And here's the states with universal licensure recognition. These aren't uniform. They're a little bit different in every state. I think one of the challenges with the universal licensure bill is really internal to the state. What do you require the board to do? If they've got to determine whether a similar scope of practice exists between when someone comes into the state, what we've found from boards is that makes it incredibly difficult and makes the process hard to manage. So if you're doing a universal licensure recognition law, you want to try to limit what you're asking the board to do as far as determining either scope or some sort of experience and equivalency. These are still good laws. States like them. We think they work well for certain professions. But again, the more you ask the board to do, I think you're limiting the effect of them. And so here we've got sort of a comparison between compacts and universal licensure recognition. So this is in your packet. You can certainly review that. But again, a lot of states have turned to these because they want more practitioners to be able to come into their states. Where compacts differ is they allow that two-way travel. So if I'm a practitioner, I can also move out of state. Universal recognition is just to bring folks in from out of state. All right, and then here's my contact information. There's our website where you can find a lot of resources. And Joseph, with that, I think I'll obviously stop and take any questions folks have.
Perfect. Sorry, go ahead, Dr. Khan.
Thank you very much. Appreciate your presentation. We can proceed with our commissioner's questions.
Andrea Peterson, you have a question?
Yeah, thanks for that presentation. So we had a little discussion in our last meeting around some of these compacts. And I know that they mentioned that there might be concerns with the unions. I don't know if you might be able to speak to if, other states have had concerns and how they might have addressed those. And then just states who haven't adopted compacts. I noticed, with nursing that a large portion, I think it was 40, have adopted those. Can you maybe speak to why some of the concerns might be around those who have not adopted those? Sorry, tough questions.
That's okay. So there's really only one compact that, and I would encourage you to reach out to the Nurse Licensure Compact. They can speak more freely about this. I want to be careful what I say. I don't want to discount the concerns, and I don't want to discount the Nurse Licensure Compact because it's operating in 42 states. That is the pushback. It is, concerns from the union. What I've been told over the years is there's concerns that it will negatively impact their ability to bargain collectively or to strike, that it could be used to bust a strike. Now, I'm not aware of that ever happening, but I'm not the one that has to live with that concern. So again, there's other folks that you can reach out to get that information. So right now, California, New York, and Massachusetts haven't enacted any of these licensure compacts. California saw the compact for cosmetologists, teachers, psychologists, and counselors move out of the Assembly, but they're not going to be able to get a hearing in the Senate. We think cosmetology will actually get a hearing, but they're not going to have a hearing for the mental health compacts. The concern is over standards. It's different for each compact. With psychology, you have to be an APA accredited program to participate in SIPAC. There are a lot of state accredited programs in California. And the reason that psychology, the SIPAC did that was, again, that's the uniform standard throughout the country. So that was the biggest reason they did that. That's one of the concerns that had been expressed. With the other, it's concerns over, a flood of practitioners coming in. We haven't seen that. Again, these things are fairly new in their in how long they've been operating. So we don't have a lot of long-term data that we can share with you. The Medical Compact recently did a study. Joseph, I can get that to you to be circulated. New York, again, Massachusetts, they believe in their licensure system, and they believe that the practitioners that they license are the ones that ought to be practicing in their state. And with these licensure compacts, there's a lot of trust. You have to trust that other states are doing the due diligence that your state is doing. We've not found that to be an issue, but again, it's one thing for us to say that, encourage them to reach out to their colleagues in other states, and it's another thing for them to have to live it. So those are the biggest concerns that I've heard from those three states.
Thank you very much. Any other questions from commissioners?
All right, Daniel, thank you for your presentation, and I appreciate you sharing sharing that study you mentioned regarding the medical licensure compact and others. And if we have further questions regarding the nursing compact, perhaps we could just reach out to you mentioned the compact contact for nursing directly.
Yeah, I can get you. It's Jim Puente. I can get you Jim's contact information.
Okay, thank you.
All right.
All
Thanks,
right.
everyone.
Thank you very much. Moving along to our next item. Joseph?
Yes, thank you, Dr. Khan. Let me share my screen really quick with everyone. I'm not going to take up a lot of your time. Just wanted to share a visual really quick. So on June 3rd, Dr. Khan approved a solicitation of recommendations to be sent out from the commission, requesting any recommendations that the public has regarding workforce. And so since June 3rd, we have been compiling any responses to that solicitation and have also shared a summary with you all in your meeting packets. So as of last Friday, a week ago, we received 26 submissions with recommendations. A summary of the common themes are on this slide. A majority of them have been related to insurance and also increasing reimbursement rates. So it says 12 here. It's actually now 15 and a majority of those are related to Medicaid reimbursement rates specifically. Others, of course, 9 related access to care. We had some related to interstate licensure, compact, and reciprocity. For different occupations, some were related to nursing, and others. We also had suggestions related to administrative barriers related to onboarding, training, and licensure requirements. And then also some suggestions related to loan forgiveness, tuition assistance, and others. So we did share the summary of all the recommendations and who it was received from. If there was any, specific recommendations that you had interest in, that's what this agenda item is meant to kind of discuss. And so prior to today's meeting, Chair Khan did ask that a representative from the Nevada Public Health Foundation briefly speak to the recommendations they submitted regarding social workers and what some initiatives they are doing and and would recommend to increase the workforce development of social workers in the state. So I believe Natalie Gutero, who's the executive director, she's present today. Hoping Natalie can provide a brief overview of the information she submitted for all of your consideration. Natalie, I see you on the screen. Go ahead.
Yes, thank you so much, Chair Khan and Joseph, for the invitation to present today, and to the commissioners for your consideration of our recommendations. I'll also be joined by Tina Gerber-Wynn. But my name is Natalie Godero, and I'm a licensed master social worker and the executive director of Nevada Public Health Foundation. Prior to taking on this role, I served as the MSW coordinator for the UNR School of Social Work. So just want to give a little bit of my background experience in social work there. And with me is Tina, who will introduce herself.
Hello. Oh, there I am. Good morning. I'm Tina Gerber-Wynn. I am working as a community engagement specialist for Nevada Public Health Foundation. And by history, I have worked for the state of Nevada as a social worker within the Department of Health and Human Services for 31 years. So I did have a few suggestions to summarize after Natalie finishes with the information sharing.
Wonderful. Thank you so much, Tina. So in both our current and previous roles, Tina and I have had the opportunity to be social workers and work closely with social workers. And currently, NPHF is working on several social work initiatives that we outlined in our recommendations that we submitted. And we are happy to answer any questions you may have about these projects after we provide a brief overview of what we have learned about social work and our combined research and experience. Social workers are an essential part of healthcare. And as with other healthcare professionals, Nevada has a significant shortage. Established state positions are often vacant at a rate topping 40% in some areas of non-clinical practice. And Nevada has an average of 1 social worker per approximately 1,420 people. It's quite a caseload, you can imagine. Social work is a community-based service, and social workers provide healthcare service in all facets of our society. And this is important to note that they're not only providing healthcare and healthcare-related services in medical settings, but also in schools, community organizations, in the military, and social service agencies, and local, state, and federal government. Regardless of their practice setting, social workers serve populations with the highest needs, and the focus of their work most often includes children and families, people with mental health and substance use disorders, people receiving healthcare, and people who are seriously ill and in need of assistance with activities of daily living. Unfortunately, social workers are often overlooked as key agents for addressing mental health, behavioral health, and social determinants of health, despite being uniquely qualified to address all 3. And what's really cool about Nevada's licensing structure is that it enables them to provide these important healthcare services at every level of licensure, so bachelor's, master's, and clinical levels. These services include screenings for suicidality, mental health assessments, interventions to restore social functioning, case management, and provision of linkages to community services. Because social workers can immediately begin addressing mental and behavioral health at every level of practice. Investing in their education provides a quick turnaround in service delivery. Moreover, social workers, clients frequently live below the federal poverty level and are Medicaid eligible. So because social workers connect people with state and community resources, they're uniquely qualified to address the social determinants of health for these populations. And this is very important because what research is showing us is that about 10 to 20% of a person's health outcomes are the result of the time that they spend with their doctor or healthcare provider, while the other 80 to 90% of health outcomes are the results of environmental conditions such as housing, transportation, economic stability, and family and social support. Therefore, including social workers as part of a multidisciplinary team provides a more comprehensive and holistic approach to patient care and addresses needs at the lowest level of care. Our combined work with people drawn to the field of social work has taught us that they are often inspired by lived experience and tend to be non-traditional students who go to school while working full-time. The bachelor and master level programs require unpaid practicums of approximately 15 hours per week, in addition to attending classes and doing schoolwork. So this makes working full-time to pay for college and living expenses challenging. And as a result, social work students often graduate with high college debt. And then they enter into careers that pay less than many other healthcare professionals who address mental health, behavioral health, and social determinants of health. In view of these important facts, the NPHF made the recommendations to develop the social work workforce that Tina will share with you now.
Thank you, Natalie. So we had a couple of ideas that potentially would impact policy development. I think the reality is we could make recommendations for private employers, but I don't believe the impetus that we would have would challenge how private companies practice. Some of the things that we've noted in our discussions and our work is that increasing the opportunity for paid internships, it seems essential to keep students in school. So we've had scholarships that we've awarded and the opportunity to speak to students, and they're working full-time and going to school full-time or part-time. And when it comes to having a field practicum experience, they have to spend those 15 hours also in the field and work full-time. So one recommendation we would have is, if it's possible, to set up funds for paid internships for people who are pursuing health and human services related careers, to allow for them to actually reduce their workload during the week and concentrate on their education, with the payoff of them actually finishing school and becoming licensed. When we spoke with the university systems, people who are in community college trying to attend 3 years there and then 1 year in the universities are often having difficulty finishing the last year because of the time demands and the as well as the financial responsibility. So that was one of our suggestions, increasing opportunities for paid internships and potentially including stipends for travel if people have to travel from the rural areas to urban areas. And I would say Nevada Public Health Foundation is really concentrating more heavily on rural Nevada for some of our workforce initiatives. The other thing we suggested is supporting people after graduation for those who are not pursuing clinical licensure. Many people enter, for example, child welfare systems or adult protective services, some of the medical social work, and most recently we're working with public defense teams who need social workers to create mediation plans and recovery plans for their clients. And those social workers don't have any special training or understanding of the field in which they're entering and the complexities of the field itself, like learning the justice system, understanding the medical system, understanding the child welfare system prior to entering those jobs. And it's quite an eye-opening and perhaps overwhelming experience in relation to what they studied in theory in school. I do know that the child welfare system does have a special track at the master's level for people to study about child welfare, but even with that extra education, it's still not enough support to encourage people to stay in that certain field of work after graduation because of the complexities of those care systems. So we would suggest developing stronger educational paths for social workers in those specialty areas after their graduation, whether it's a workforce center or some kind of any kind of entity that would train people and offer more guidance once they're in the field. I know people have supervisors in any job, but we're talking about something extra and not on the job training that is really related to processes that are run by the agency, but we're talking about training of the theory of social work. And that kind of evolves to the next thing we're suggesting, which would be occupational wellness training, support, mentorship, and awareness that would be held separately from an employer. I know there's employee assistance programs where we're really talking about a specialty group that would help support people in the field. I think one of the things we know in speaking to social work staff is there's secondary trauma related to all the pain that they see in their jobs and distress and lack of solutions for people who are really in desperate situations. And I think what we've talked about is having support, almost a support group or some kind of mentorship group that allows for expressing and addressing that secondary trauma. I think people in the healthcare field now understand about ACEs and all the horrific events that happen in childhood that create personality and behaviors as adults. This also happens during your career. And I think all the people that I can see attending this meeting have probably all experienced some level of distress and lack of support that makes it harder to stay in your field of work. So we're talking about having more specific opportunity for social workers to have support within their job, within their field, and separate from employment resources that are more personalized and independent of an employer. And then let me see, we also had one suggestion about looking again at the state's loan repayment program. I know that it's just developed and the regulations were just created for the state's loan repayment program based on a bill that was passed in the legislative session 2023. One of the things we note is there's a lot of confusion about social work licensure and who is eligible for loan repayment. And we would like to suggest that master's level social workers who are not pursuing clinical service, as well as bachelor's level social workers who will not be offering clinical services, should be considered in that loan repayment program. Right now, it's written for providers of healthcare, which social workers are, but it's really geared towards a higher level of clinical social worker versus a bachelor's, master's level who is not working in a doctor's office or a medical setting, but they might be working in a field office for the Department of Welfare and Supportive Services or Child and Family Services or Developmental Services. So they wouldn't qualify for loan repayment as we read it under the current and newly adopted regs. So maybe some investigation and ability to widen that a little bit, especially in rural areas where the vacancy rates are so high for any kind of social work or case management positions. And
Thank
in
you,
general,
Tina.
yeah.
So just for the sake of time, no, I appreciate that overview, the background, and I also appreciate you going over the regulations that were passed this week. The state treasurer's office bill that passed last year, creating their healthcare loan repayment program. Those regulations were just approved by the Legislative Commission this week. So definitely we'll be tracking that to see how their program's going to be rolled out and implemented. But did appreciate that they are allowing all providers of healthcare, including social workers of different levels, to qualify to apply for that funding. Now, commissioners, this agenda item is not specific to solely Natalie and Tina's recommendations. Truly appreciate them providing a deeper dive into the needs and some ideas on how to improve workforce development for social workers. But this agenda item is also an opportunity for you to ask any follow-up questions or request additional information that you might have regarding any of the recommendations we received thus far. So I will open it up to you and the others to have any questions or comments that you might have.
Any questions from any commissioners?
Andrea Peterson, go ahead. You're muted,
You're
Andrea.
muted.
You said this is open for any of the recommendations that have been submitted. I just wanted to confirm. Is that okay?
Yes, thank you.
Okay. I took some time to review those recommendations, and I'm really grateful for those that, took the time to write out some really thought out different things. And I had noticed the same trend that you had pointed out, and that is a lot of them are addressing Medicaid reimbursement rates. And so I know that you had mentioned the next meeting is going to have a presentation for Medicaid. I'm just wondering if we can make some, some specific, if I can ask some specific questions as she addressed. Is that okay if I just kind of quickly go through those?
Absolutely,
Yes.
yeah.
Okay. So I'm just wondering, number one, how does Medicaid conduct their rate review process every 4 years, if that can be addressed? And then what is the decision-making process based on the reviews that come out of that every 4 years to raise rates? And then how do those rate reviews actually translate to increased rates for providers that are participating in managed care? It's very important to understand that. What are the policy levers that Nevada specifically needs to consider in order to increase rates and to, increase access to care while ensuring that quality of care, so that we make sure that we're thoroughly understanding that process when we're, trying to make a recommendation here. I'm wondering if the most recent rate review analysis can be presented so we can see the recommendations that were made there. And then just as I was kind of trying to review through that rate analysis, it looks like there was not great participation as Medicaid was trying to engage providers in that. I'm wondering what they've done to modernize their communication to get better engagement with them. And then kind of just the last question, but are some of the low provider rates a symptom of a different problem? So if Medicaid potentially could maybe address some of that too.
So this is Chair Khan here. Very, very good questions. What I would suggest is, since we're having a presentation by them at the next meeting, these are all the questions that the Medicaid presentation should be able to address. And to emphasize the subject that you are talking about, Medicaid reimbursement is a part of the governor's executive order to be looked at also. So it's my thought process as of right now that we may end up discussing that based on all of your input as a possibility for a BDR, since it's part of the executive order, and the number of people, the majority of people have expressed concerns about Medicaid reimbursement. So I think there'll be a lot of opportunities to discuss this for sure. But I think we would need some comprehensive presentation by Medicaid people specifically to answer a lot of your questions that you have raised.
Yes, and Joseph and Chair Khan, if you would like, I can put that in writing. So if you want to pass that on to Medicaid, just to ensure that their presentation does include that, I'm happy to do that.
We're happy. We took notes, and we'll be happy to reach out to them and ensure that they cover that during the next meeting during their presentation. So appreciate you.
Thank you.
Listing that out. Bethany, do you have any questions?
Maybe just one additional one around, do they have any sort of evaluation? This is specific to Medicaid again, around evaluation of providers and the differences, meaning providers that participate in Medicaid versus not, only that they only accept Medicare and commercial, and trying to understand what the delta is there and the gap as a part of all of Andrea's questions related to the reimbursement rates too may be helpful.
Yeah, so that's also a good question. Currently, those who are not providers of Medicaid or who do not accept Medicaid, keep in mind there are two components of Medicaid services. A very small component is what they call as a fee-for-service Medicaid that the state directly manages and controls. But a much larger number is under managed Medicaid. So the state has outsourced the Medicaid services to these multiple managed Medicaid companies. And the process of outsourcing, the credentialing, etc., of those physicians who have agreed to accept those managed care contracts is the responsibility of those managed Medicaid companies. So they would do that, and there are more providers in managed Medicaid side than they are in the fee-for-service Medicaid side. Obviously, because their reimbursement is better, I wouldn't go that far to say how much better, but they're relatively better than the Medicaid fee-for-service. But we'll have all that information, or should have it, at the next presentation. We'll allocate some extra time, Joseph, for that presentation and questions at the next meeting.
Absolutely. We'll do, Dr. Khan. Andrea, did you have a follow-up?
I was just going to say, I think that question I asked might help with that is, how do rate reviews translate to increased rate for providers participating in managed Medicaid? Just helping us understand that process.
Sounds great. Yep, I will forward all this to Stacy and definitely touch base with Administrator Weeks before our next meeting to ensure that we can prepare a presentation for you all and definitely allocate some additional time because it's probably going to be a lot to cover and a lot of follow-up questions, I'm sure, from you all. Unrelated to Medicaid and the reimbursement recommendations, any other recommendations that were submitted that we would like to discuss at this time? Don't feel like we have to discuss everything that was submitted, but this is just an opportunity to go over that if you would like. Right. Hearing none.
All right.
Oh, Bethany, did you have something? Sorry.
I'm sorry. I'm very slow on getting my hand put up, obviously. Yeah, I appreciate the compact discussion earlier. And I think it did appear to be one that was, in the running in terms of the items that people were suggesting. And I just, while I know that has had a lot of headwinds in the past, continue to feel like there could be a lot of meat there across a number of categories. So not just nursing compact, because I think that's been probably the most contentious area, but across a number of domains. And when you see the stats related to the fact that 42 other states are doing this, it feels sort of like we're getting down to in the minority. So would appreciate us continuing to kind of understand how we might be able to bring that forward, or at least continue the conversation.
All right, that's a good. Thank you. If nobody else, we can move on. Anybody else?
Not seeing any. And so moving on to agenda item number 7, going to share my screen briefly one more time, and then I'm truly just going to open it up to all of you so that you have plenty of time to have your initial BDR discussion. Just give me one moment here. Okay, so agenda item 7, it is for possible action today. It's review and discussion of possible BDRs and other recommendations that align with the governor's executive order. And so this slide here, just a really quick reminder at our upcoming timeline for our BDR submission. So today we're having our initial BDR discussion, and then following today's meeting, just so you all are aware, I'm going to send out a form for you all to fill out to provide up to 3 initial BDR concepts that you have. We're going to then compile the list of all the BDR ideas that you provide and then resend those out to you and ask for you to rank them from your personal stance on, what you think the top BDR ideas that the PPC should begin to narrow and discuss. And then hopefully by our next meeting in July, I will be able then to present a poll results of all the ranking that you all provided, which will hopefully help you all narrow your focus for your BDR ideas that we have to submit by September 1st. That's a hard deadline. So, we have next meeting in July. There might be a need for at least, one, potentially two more meetings in August as we finalize these BDR topics. And I do apologize that it's such a short turnaround. I feel that other boards and other people in your position that have to put forward BDR concepts have had a lot more time to really digest information and provide some concepts that they would like to put forward. So appreciate, I just appreciate your time and respect it, and hopefully we can meet this quick deadline coming up. So really quickly, just wanted to provide, this is simply a suggestion as you start to talk about different recommendations, to really put them in different parking lots of ideas. So this first one on the left, those would be any ideas that you have that are potential BDRs that you would like to put forward. And then the second box here could be, maybe it's not something you want to put forward as one of your BDRs, but it's still a formal recommendation that you believe aligns with the governor's executive order that we could then include in our formal letter to the governor and the legislature. And then that could potentially be a BDR that maybe another entity carries into this next session as well. And then finally, this third box, just it's an idea that sounds good, but maybe there's additional time needed for further review before you make a formal recommendation or decision on the topic. And so really quickly, again, this is the executive order. There's 6 areas that you are all asked to provide recommendations towards. I won't go into those. You all have this in your packets. But then following last meeting in May, a few of you sent some ideas that you thought would relate to the executive order. I tried to compile those and just list them on these next couple slides to show what section of the executive order they relate to. So just for an example, I won't go through these one by one, but Dr. Curry-Winchell, she recommended, increasing physician diversity to assist with recruitment and retention of, for example, some of the graduate medical students. Might not want to leave Nevada if there was a more diverse workforce. And so there's other recommendations here that are, and there's also a table in your packets that have a list of all the ideas that have been submitted at this time. But really just want to open it up for you all now to have as much time as possible today to begin this conversation, knowing that following today's meeting, I'm going to formally ask each of you to provide up to 3 BDR ideas, and then we'll begin to rank those going forward. So with that, I will stop talking and hand it back over to you, Chair Khan.
Yeah, so just keeping in mind, we are expected to present up to 3 BDRs, but doesn't prevent us from presenting 2 or 1. Before the last session, till the very end, we had narrowed down to 2. We didn't have a consensus for 3, but eventually we did get there. So just keep that in mind, that it says up to 3 BDRs that we could recommend for this session. What happened before the previous session was the items, there were many items of importance to various commissioners. They were tabled in for the next commission to come in and perhaps pick it up from there. And Joseph would have access to that, but we already have a lot here to handle. Whether we'll get to the previous ones from the previous commission members, we'll find out as we go along. So I'll open it for the commissioners to chime in what they have in this aspect. But as Joseph mentioned, we will poll everybody, take the priorities, the majority ones, we'll narrow them down to 1 to 3. We will need a robust discussion for each one of those with the Attorney General's input also on the language. And just to remind all of the commissioners, it's a very tedious process. The Legislative Council Bureau also chimes in on minute things like language, one word, this word or that word. So in my opinion, and from past experience, my suggestion would be the sooner we come to some consensus of the top 3 BDRs, the sooner we may be able to narrow down and get it through the DAG and everybody else to meet the deadline. Any comments from any commissioners? None. So moving along, you have anything else, Joseph, before we move to the next one?
No, Chair Khan, I don't believe so. I understand that, it's a lot to ask of you to just come up with ideas to present at this moment. So definitely we'll follow up with you after the meeting to start requesting your BDR topics. And then, thinking ahead, as we talked about with Medicaid presenting next month, so if you provide some initial topics that we can begin to narrow down now, and then, following the Medicaid presentation, if there's some additional ideas that you would like to have, we can definitely discuss those, whether they're going to be a BDR topic or just an additional recommendation to include. But yeah, we will appreciate all of your time and hope that you can respond with information. Apologize for the short deadline, but Andrea, did you want to say something?
Yeah, I would just kind of throw one potential idea out just for people to think about because it has come up. But just maybe looking at a study that would be looking at the reasons for providers not participating in Medicaid. I don't know if anything's been done, and maybe that would be worth, if you can see, Joseph, if anything has been done so that we're not making a recommendation, it's already out there, but to better understand that.
This is Chair Khan. I can partly answer that question. In the past, during our commission meetings, and I believe that maybe one of the reasons for the governor, in addition to having received solicitation himself or his office through the providers, the main issue is the reimbursement. That is the provider's primary reason not to accept Medicaid. They have made presentations to the legislature about it. They have been told it's a budgetary question. Budget has only so much available, and the priorities of the budget in the past have not necessarily focused on this aspect of healthcare problem.
So definitely that's something that we can have you submit, Andrea, and others. And if that's something we want to dig into, I'm happy to request Medicaid to hopefully cover that in their presentation. But if it is something that we want to put forward as a BDR or just a recommendation in general for a study to occur, that's something we can discuss going forward. Any other commissioners have any BDR topics they'd like to briefly bring up or discuss? Jalen?
Hi, I just have a quick question, and I don't know if we know the answer on this call or not, but I have a question about the Nevada Nurse Apprentice Program. We've been participating in that for the last year. It's a great program. I love it. But is there a way to get like an ROI on that to find out, a year has gone by, have any of those nurses that have graduated stayed in Nevada? Is the program accomplishing what the intention is?
Thanks, Jalen. And formerly I helped with that program. So I just know that they are actually required to provide a annual report to the legislature on basically what you're requesting, the amount of funding that's been allocated to the program, the amount of nurses that have now been retained following graduation by Nevada facilities. I believe their next report is actually due in August. But if I need to reach out to the Nevada Rural Hospital Partners who is managing that program, I can request an update on what the current number is. Because I agree, it's a beneficial program, and I know that it's a ARPA funded program. So it's one of those where, once the funding ends, the program might end as well. Not to say that facilities and nursing schools can't still have nurse apprentice programs in the state, but the funding to then reimburse hospitals and other facilities for their nurse apprentices, that will go away unless additional funding is allocated. So happy to get more information to you on that.
Perfect, thank you.
Any other comments or questions?
And if I may, this is Chair Khan again for the record. There's a summary presented in your package by Joseph about the current commission priorities based on the governor's executive order. And it's A through F. And one could use that as a template when we are deciding our priorities so that we are within the confines of the executive order. It's just that it's left up to us to decide which top 3 numbers from that that we are going to recommend for BDR. That doesn't mean the others cannot be considered in a different forum or directly at the legislative session by other interested parties. So I think that would be a good outline of those A through F items in the executive order and narrowing down our BDR priorities.
Yes, Chair Khan, just so you all know, and I will share it immediately following this meeting, but the document that I'm going to send to you all requesting your ideas, it's going to have the A through F sections there, and it's going to ask you to relate, whatever your topic might be, what section of the executive order does it relate to, A through F. It could be multiple sections, of course, but I agree that hopefully whatever BDRs that you put forward would relate to the executive order and hopefully address workforce needs of the state. So more to come for you all.
Any other comments or questions? If not, we can move to our next item. You see any hands up, Joseph?
No, Chair Khan, I do not.
Okay, so we can move to item number 8 on the agenda for possible action, which is review and approve semi-annual PPC report required per NRS 439918. Joseph, the Executive Director, Joseph Filippi, would address that.
So thank you, Chair Khan, Joseph Filippi for the record. So within each of your packets, the draft semi-annual Patient Protection Commission report, it has been included. So pursuant to NRS 439.918, the commission is required to provide a report every 6 months to the governor and the legislature. That report should include a description of any meetings that were held, any issues identified that negatively impact the quality, accessibility, or affordability of healthcare in the state, and then any recommendations for legislation, regulations, or other changes to policy or budgets. And then in addition, as you all know, the governor's executive order requested you all to include recommendations on how to address workforce shortages in the state within the semi-annual report. So prior to drafting the report, you had all only met once this year, so not a lot of opportunity to provide any formal recommendations at this time, unfortunately, but I explained that within the report, as you hopefully have seen. And then, basically, we can always provide more information after this next 6 months goes. So just want to open it up to you all for discussion. If you have any recommendations on anything that should be added and or removed in the report prior to me submitting on your behalf. The report is due July 1st. So we have a little over a week to make any last minute changes that you all have. And Wendy, go right ahead.
Thank you very much, Joseph. I want to compliment you because we all didn't really land until the middle of May. And I think you nicely declared what the actions have been of the commission, but you also identified topics that certainly in the healthcare provider rankings was very informative. And I just, and you have said where we're going forward. So my compliments to you. I think you did a nice job.
Thank you, Commissioner Simmons. Appreciate that. Yeah, I believe that the rankings was kind of beneficial just to show what the issues are and what we're trying to address. Anyone else?
So this is Chair Khan. Go ahead, please.
Hi, this is Dr. Bayo Curry-Winchell or Dr. BCW. I just wanted to echo what she mentioned. Joseph, you've done a fantastic job. Now there feels like there's an outline, there's progress, and we can actually see, what's to come. So I would like to shower you with a compliment of well done in getting this all put together and being able to kind of think about what are we going to accomplish. So thank you for that.
Yeah, I certainly reinforce that opinion from my point. It's been a pleasure working with Joseph, and I can say this very clearly in my mind. He's on top of things, reaches out to me almost every other day, which is what we want. And it's been really a blessing for me personally to work with him. Having said that, one little comment I would like to make for the presentation that I would like to see from the Medicaid people. Number one, our standing and Medicaid fee-for-service reimbursement amongst the other states compared to them. Number two, our reimbursement through managed Medicaid to the providers and how it compares with the managed Medicaid products in other states. So, because keep in mind, the fee-for-service Medicaid population is very, very small. Bulk of the Medicaid population is with managed Medicaid companies. So we need to look at that also, because that has the biggest impact on the Medicaid population and whether the providers would want to be on their panels or their networks or not be on those networks because of reimbursement or other reasons. So I think that's something that should also be included in their presentation when they do that next time, cover both areas.
Thank you, Chair Khan. Joseph Philippi, for the record, I'll be sure to include that in the request to Ms. Weeks. Any other comments on the report as drafted?
And if I may suggest at our next meeting, and I would like the commissioner's views also, this narrowing down the discussion that BDRs can be exhaustive, as I alluded to earlier. So we should allocate enough time for the commissioners to be able to, really hash down and thrash down the details of the items, the top 3 items that they would want to consider. So we really need to allocate enough time. And other than Medicaid presentation, which may take some time from questions also, any other presentations the commissioners want to be considered, keeping in mind the time constraints to discuss the various subjects?
Bethany, you have your hand raised. Is it related to the report or to Dr. Khan's question?
To the report. So
Okay.
I'll wait if there are other comments.
And happy to, if you have any requests between now and July on a specific presentation, I will just reiterate that, we've had a lot of outreach from different stakeholders as well that have been interested in presenting to you. And I think, it's appreciated to want to have as much information come before you. But I'm hopeful that the solicitation of recommendations and the suggestions that we're receiving through that provide an outlet to still provide you with recommendations and information. And then we can always follow up with whoever you would like us to for further detail. But I definitely think there's been a lot of, as was mentioned today, a lot of discussion about Medicaid and different opportunities there. So welcome a presentation from them next month. But as Chair Khan has touched on, really are hopeful that you have plenty of time next meeting, as it's one of the last meetings before our deadline, to really narrow down your BDR focus.
This is Chair Khan. One more comment, Joseph, for our next meeting. Since Medicaid is going to present their perspective on all of this, it will be important for us to see if we can get some opinion from the provider side as to what is the reality that they are facing firsthand, rather than what I think is going on or some of us think is going on, which means the providers, there are various provider groups, at least on the medical provider side. One can look at the medical association or others, and on the hospital side, you can look at the possibility of hospital association. How is it impacting in providing services? Because they are the ones who are in the trenches and facing this reality.
And I guess, Chair Khan, we could discuss it now or offline, but just there's been plenty of different provider groups that have, reached out and mentioned Medicaid reimbursement rates. So
Yes.
if we were to ask for a presentation, selecting which associations we would want to potentially hear from, or if we just want them to provide something in writing for you all, we could request that as well. You mentioned, the Nevada Hospital Association and Nevada Medical Association, who I believe, they're over like physicians and PAs and whatnot, but there's other provider types and groups and associations that I would assume would want to provide their input as well. So just, again, talking about our time constraints, if we were to hear from one association and not others, wouldn't want to do that. So maybe just include, still, we're going to continue to regularly provide updates on any recommendations that we receive through the solicitation. Hopefully, if you'd like me to, I can reach out to those different associations you just mentioned and see if they can touch on Medicaid specifically.
Yeah, and others.
Will do.
At least they can give it in writing, because we have a very large population of providers in the community. The primary care providers, the physicians and physician extenders is one component of it, but direct reimbursement of Medicaid also goes to other providers like physical therapists, nurse practitioners who are independently practicing in the community. So some of those organizations, smaller in size perhaps, can also submit it in writing.
Perfect.
To us ahead of the meeting so we can look at it.
Okay. And we have a few
Go ahead.
members with their hands raised now. We'll start with Dr. Bio-Curry-Winchell. You want to go?
Yes, I just wanted to, when we submit, we were talking about should it be in print or having them actually do a presentation. I think there's power in having at least a blend of it, because I think when you can hear those stories of those clinicians, as the chair mentioned, whether it's different professionals, whether it's physical therapists, physicians, and so forth, but really hearing the impact of the low reimbursement and how it has impacted their practice and their ability to really see Medicaid patients, I think that would really kind of put more color behind this issue that we continue to hear about. But stories can be so powerful and can also be helpful for us when we are looking at resolutions or ideas.
Thanks, Dr. Curry-Winchell. Appreciate that. Okay, we'll move on. I'll just go and just pick in a box here on my screen. Wendy Simmons, you want to go?
Thank you, Joseph. This dialogue and this conversation and the energy around where we're going forward. I know we've got the focus of the BDRs and we've got a tight timeline on those recommendations, which will bring substance to future planning. But a recommendation back to your report. I'd like to offer for your consideration under the subject of collaboration. Because I just heard it with the provider words and all these different things, that we're not so much government focused in all of our dialogue, but we are also extending invitations to public-private sector relationships. So I would probably put that language in there, public-private sector relationships, bringing business communities that have impact based on what we recommend in the future and other government bodies recommend. So that was my only add-on for you. Thank you, Joseph.
Thank you for that. I appreciate it. And I will go ahead and make that edit under the collaboration section.
Just one quick note as the lawyer from the Attorney General's Office for Open Meeting Law, it would be helpful for you guys, since this is agendized as an action item, to make some sort of formal motions on some of these things. And you could combine them into one motion, or you could do them separately so that there are actual formal votes on these changes that will be made to this report, either in one motion or multiple motions.
Thanks, Gabe. So we have feedback from Wendy, which we can make a motion on, but it's up to you if you want to continue to go get all the feedback and then make one last motion at the end. So we can go ahead and
go with all the input and then make one motion, make it simpler.
Thanks, Chair Khan. So Jalen Behunin, you want to go ahead?
Yes, thank you. I just have a question on the BDRs. What you gave us, is that all we have to go on, or is it possible to get like some sample or language that the actual bill will say to help us kind of really understand, take it out of a general discussion and make it a more targeted discussion? Is that possible?
So I guess we would need to know what topic you all want to focus on before we get into what the specific language is going to look like. So typically, it's my understanding that once we have a concept in mind or a issue that we would like to resolve with the bill draft, then we provide, initial language to the Legislative Council Bureau, and then they have these staff members who are then assigned to review that, and actually they have lawyers as well, and so they can actually draft the actual language that the bill will have. They submit it back to you all for review. And then once we provide that final review and approval of their draft language of our concept, then they put that forward to the next legislative session. So,
okay, thank you for clarifying the process.
Go ahead, sorry.
I just said thank you for clarifying the process.
no problem. But if you all, like, when you're thinking of this, if you have a specific NRS or section of statute that you have in mind, and you're thinking maybe if it was worded differently, it would help address this area, please share that with me with your recommendation, and we can look at different statutes or different bill language further, and maybe pull different pieces of the language to hopefully come up with a draft that addresses what we're trying to resolve with the concept. But Bethany, go ahead.
Just a question about after the submission of the BDRs occurs, does the commission continue forward in meeting, and kind of what are the next steps after that piece? And then I have one other comment after that, but.
Yes, this is Chair Khan for the record. Yes, after we have submitted the BDR and Legislative Council Bureau has finally given its okay, basically, then it proceeds into the next legislative session for discussion, debate, first through the committees, relevant committees. And then after the committees have gone through that and any changes, modifications, etc. are needed, are made, then it goes for open debate and discussion at the legislature. And then both houses have to vote on it. Keep in mind, the language gets tweaked a lot in that process from where we may have incorporated it in our recommendations. That gets tweaked over there.
And this is Joseph Filippi for the record. And Bethany, I think, more towards our commission meetings with how that will look after we submit the BDRs. We are still required to and should be meeting, in my opinion. Part of your role is to submit BDRs, but additionally, it's to review different issues related to access, quality, and affordability of healthcare. So we can continue to do that via meetings and requesting different pieces of information for you all to review through presentations and other forms. But I think that we still are working to address the governor's executive order related to workforce even after we submit BDRs, and so I perceive the future looking at, like, after we get the BDR submitted, we will then continue to focus on addressing the executive order and providing formal recommendations in the letter that we then would submit January 1st. And then hope, that would be our report that would be submitted prior to the legislative session starting in February. And so that would give you all an opportunity to then share any other recommendations you have related to workforce that maybe we didn't submit as a BDR, but that other policymakers could then review and consider as the session starts in February. So that's how I perceive the next few months looking like after we submit the BDRs. But ultimately, it's your commission. It's up to all of you to what you want it to look like. So.
You're absolutely right, Joseph. This is Chair Khan for the record. Yes, other subjects could be discussed and put on record in addition to the BDRs. and they are valuable not only for the governor's office as to what the commission thought after full deliberation and taking input of the public and the stakeholders, and becomes a document that the people at the state bureaucracy also look at where was the interest of the commission, which did the due diligence on those subjects in addition to the BDR. So it's valuable to document our perspective on other areas.
That's great. And I guess I was hoping that that is what you were going to say, just because of the level of complexity and the different, multitude of issues. It feels like there's more time needed to spend across some of these domains. So that's great. The last, maybe just one comment on the Medicaid piece that I think we're trying to get at, that might be something that Stacy could help us with, is understanding the dollars that actually go to patient care reimbursement as a percentage of the total pool of Medicaid funds. Just because I think that there may be some interesting dialogue there that we would have in trying to understand that. And not only just for the fee-for-service population, but also the MCO population, because I think those may look different.
Yes, a very, very important and significant question you asked, in my opinion. Reason coming from a provider side of the issues, I think that should be brought in with the people presenting to us in the next meeting. This particular aspect as to what proportion of it really goes towards patient care versus how much is going towards administrative, non-clinical services.
Thank you all. We'll continue to gather all that and request it for the next meeting. Andrea?
Yeah, I just wanted to ask, because when we talk about workforce development, I think that licensing is a frequent, another topic that comes up. I wanted to ask the commission if there's any interest in having any type of a presentation around licensing, and if there is a report. I think there's something that is generated that kind of talks about, how the licensing boards can be held accountable, maybe for things like how long it takes to get a license. But I just wanted to throw out if there's any interest in having some time or a presentation specific to licensing.
Yeah, this is Chair Khan, if I may. At the last commission discussions a year or more ago, this was discussed. And if Joseph, you may want to pull out the information. As I recall, the medical board had come and made a presentation or sent something in writing about this very issue as to how cumbersome is it, etc., whether fees is the barrier, or is it just that it's too cumbersome? I can tell you right now, if you listen to providers and the presentations made in the past of the commission, the perception of the provider community is that the process is across the board very cumbersome. And it takes a very long time and may take up to 6 months sometimes to actually have your license in hand. So if we have that in the past information, then we can bring it to the commission so that we don't duplicate it. If we don't have exactly what is being requested by the commissioner, then we can certainly look for some more additional information.
And this is Joseph Filippi for the record, just so you all know, last session a bill passed that created an office of boards and commissions, which I believe was with the intention was to have an oversight, a single authority over the different licensing boards. That office is included in the Department of Business and Industry. It's a brand new office, and I've made contact with the deputy director over that office, and she is an office of one right now. I guess when the bill passed, it's my understanding it didn't give her a lot of authority or staffing, and so she mentioned that she's going to be working with her department to then request additional staffing and other other ways where she can use her office to I think follow what the intention of that bill was. And so curious to see how that's going to look this next session as far as having a single state authority over the occupational licensing boards, and whether or not they would be held to different metrics and accountable for the time it takes to license a provider. So I don't know if that information is available at this moment, but definitely willing to follow that and continue to communicate and collaborate with their office to provide you with additional information.
I think it would be helpful if we can know what is available, just so that we don't make, somebody doesn't make a recommendation that's already been included in that.
Mhm. Understood. So yeah, and Dr. Khan, I heard you. I will look back through the past PPC meeting information to see if I can find what the conversations were like previously and share that with the group. I think we're going to look for a formal motion now to regarding the report. So if someone has a motion, I know that there was one recommendation to include public and private sector relationships mentioned within the collaboration section of the report. If there's any other recommended edits, now would be the time to state those, and then hopefully someone's willing to make an initial motion.
Do we have the language of the motion?
Joseph, I'll be more than happy to originate the motion. I move that within the construct of the report that you presented, that we'll be sending forward under the topic of collaboration, the interest in working with public and private sector relationships.
I'll second it. This is Bethany.
Any discussion on the motion? If no more discussion, all those in favor, please raise your hands. Any opposed? So the motion carries, right? Joseph, you can see the hands better.
Yep, there was no opposition to my knowledge, so I believe there was a unanimous approval.
Yeah.
And thanks to our DAG for keeping us out of trouble.
Yes, we are always thankful to them. Any other comments as we're moving along? Joseph, you have anything else before we go to the next item of public comment?
No, Chair Khan, I don't. I appreciate everyone's review of the report, and I will make those edits and get it submitted by the deadline. So thank you for that.
Yeah, before we go to the public comment, I would really like to thank all the commissioners. This was a very smooth meeting, and I'm personally a stickler for time in the interest of all of you who volunteer your time here. So the more efficient the meeting, the more time you have for your own other professions and work. So thank you very much. So we can go to the public comment, Joseph.
Thank you, Chair Khan. Sorry, didn't know if someone had said something. So this is the last opportunity of today's meeting for public comment. Again, if you're calling in, please press *5 to raise your hand to provide public comment. If you're joining from computer, just raise your hand through the Teams feature at the top of your screen. Any comments will be limited to 3 minutes. All right, Chair Khan, I'm not seeing any hands raised, so I don't believe anybody wishes to make public comment this morning. So.
Okay. Oh, great. Thank you. Before we adjourn, the question for you, Joseph. Do we have a tentative date for the next meeting?
Yes, thank you, Chair Khan. Joseph Philippi for the record. Our next meeting is scheduled for July 19th. I believe the majority of you said that's when you would be available. It's a Friday, so the third Friday of the month in July. So my intention following today's meeting, as I mentioned earlier, is to send you all a document requesting your up to 3 BDR ideas that you have. I will then compile a master list of all of those and then ask you all to rank those ideas prior to our next meeting on the 19th. So hopefully we can narrow down your focus prior to then on some topics. It might not be 3, but hopefully it's not 20. And then just so that we have a narrower focus to continue our discussions on your BDR topics. So that's my intention of next steps, and I will be working closely with you, Chair Khan, and others. We'll provide any follow-up information that was requested today. I'll be working with Medicaid as well related to their presentation that will be upcoming next meeting, and happy to support you between now and then in any way possible.
Any other thoughts before we adjourn? If not, we stand adjourned. Thank you very much, everybody.
Thank you.
Thank you all.